Hi, I'm Dr. Tariq. I'm one of the transitional year residents at Kendall Regional Medical Center. The topic of my presentation today is incidental discovery of neurosyphilis as a reversible cause of dementia. Neurosyphilis is a bacterial infection of the brain or spinal cord caused by Treponema pallidum. It typically occurs in people with untreated syphilis, commonly around 10 to 20 years after a primary infection. Cognitive decline is one of the late manifestations of syphilis. Although uncommon in the developed world, our patient with a history of dementia came to the hospital. He underwent a workup for potential reversible causes of impaired cognition and ended up being tested positive for syphilis. I present to you today our 77-year-old male with a past medical history of hypertension, diabetes, functional decline, and dementia. Not on any medication. He presented with after a mechanical ground level fall. He sustained bilateral sacral fractures, fracture of the L5 transverse process, and a retroperitoneal pelvic hematoma. On admission, he was evaluated by orthopedics and neurosurgery for his injuries, and they were considered non-op. While investigating the different causes of dementia, he was found to have serology positive for syphilis. On further questioning, he denied any prior history of syphilis or prior treatment, and he was not aware of him ever being exposed. After appropriate counseling, we decided to pursue further workup, and a lumbar puncture was done that showed elevated proteins in the CSF. The patient was started on penicillin IV, and after completion of the IV treatment, he was going to start treatment for latent syphilis with benzathine penicillin. And an order for midline was placed so he could receive the medication. So he stayed in the hospital for 10 days, then he went back to his assisted living facility and established care in an outpatient setting. On the physical exam, he was awake, alert, was oriented to place, situation, and person, his own name, was disoriented to time, and was not able to correctly state his age. Musculoskeletal wise, there's normal inspection, but left hip tenderness and left leg range of motion was limited due to hip pain. Neurological exam, the patient was able to follow one-step commands and name simple objects. Expressive and receptive language were intact. Appropriate social pragmatics like reciprocal conversation and eye contact was there was pressured speech. No motor deficits. There was decreased sensation in the left lower extremity. The lab workup revealed as serology positive for syphilis and Treponema pallidum antibodies. The CSF analysis revealed that the total proteins were elevated and even serum IgG levels were really high. Imaging wise, there was brain CT, there was spine CT, and they were pretty much negative for any findings. The purpose of presenting this topic is to say that for sure syphilis still continues to exist in this modern era. It is a disease that can be treated easily if diagnosed early, and it will also prevent progression to the complications and disabilities. Whenever we see a patient in our everyday encounters, we must put syphilis as a differential on our list, and we should obtain a good history, do a good physical exam, get support from imaging, and obtain a lab workup, which if positive for syphilis, we can end up even doing a lumbar puncture. And the presence of increased proteins, especially greater than 45 milligrams per deciliter in the CSF, and high levels of IgG, they favored the diagnosis of neurosyphilis. In our case, even though our CSF VDRL was non-reactive, but the presence of elevated proteins and serology is good enough to have a diagnosis for neurosyphilis and start to treat with antibiotics. Working up a neurosyphilis in a patient with dementia can produce a favorable outcome because of the use of medications as simple as penicillin, the patient can start showing improvement in cognition. Thank you so much for your time.